Assalamu alaikum wa rahmatullahi wa barakatuh. My topic for today is the challenge of diagnosis of tuberculosis in children. At the beginning, I just want to give a short hint about the epidemiology of the TB in the 21st century. According to the latest report by the WHO in 2022, it stated that 1/4 of world population are infected with TB. 10.1 million cases and 1.8 million deaths occur every year worldwide. There is about 15 to 20% of the global TB disease occur in children less than 15 years of age. Besides, nowadays there's increasing numbers in the developing world, and this is due to the HIV epidemic. As in HIV cases, this is a chance of 34% of co-infection. Also, the poverty, overcrowding, malnutrition, and all contribute to the condition. Also, the emergence of multiple drug-resistant TB and extensively drug-resistant TB with incomplete treatments by the patient increase markedly the situation. Together with the breakdown of the TB control programs in most of these developing countries. Here we come to the diagnosis of TB. Diagnosis in pediatric age is really difficult and challenging. We have a lot of cases where the clinical picture strongly suggests the TB infection, but on the other hand, all the investigations are normal. So it's a big dilemma for us as a pediatrician to consider this patient is a tuberculous patient and start an anti-tuberculous, or just wait and take the risk of spreading of the disease. Here are some of the reasons why it's difficult to detect TB in children. Also, according to the WHO, in children, the detection gap, which is the difference between the infected cases and the reported cases, is larger in the children group rather than any age other group. 69% of the missed cases are in children less than 5 years of age. Besides, the challenge in the diagnosis, it includes the definition of the case itself. As per WHO, it requires the presence of a positive sputum smear, which is very difficult to be obtained in children. Children are commonly have poor bacillary count, and they are more negative in culture. And this culture, at the best chance, will give us 50%. The vague and varied clinical presentation of TB in the pediatric age group make it very difficult and confused with other infectious diseases. The risk of progression to the active disease is about 40 to 50% in the first 2 years of life. So it's very difficult to take time in the diagnosis of this such vulnerable age group. And it's 5 to 10% for elder children and adults. The direction of national TB control programs in reporting child TB case, they neglect. If it's a child, it will be neglected to report TB case. Besides, and the most important, up to now, there's no widely available gold standard diagnosis for TB in children. Screening of the TB is the first step for the diagnosis. And the screening should be done for all household contact and other contact with cases of TB. People living with HIV case, poor communities, homeless communities, communities in remote or isolated areas, migrants, groups with limited access to the healthcare centers. And this screening should be conducted by using the symptoms, chest X-ray, and the WHO recommended rapid diagnostic test, which will be mentioned later on. To diagnose a patient with TB, we'll do like a stepwise. We'll start with a careful history taking, including history of a contact with TB case or any symptoms consistent with the disease. Also clinical manifestation, the symptom and sign of the disease. And of course, our traditional tuberculin skin testing, which is done for all patients suspected to have tuberculosis, bacteriological confirmation, histopathology when possible, and imaging will help us a lot. As we see, the symptoms of the tuberculosis in children could be general and non-specific. It will start with fatigue, night sweats, reduced appetite, weight loss, persistent cough. Then, beside the other symptoms which will be different according to the site of infection. If it is pulmonary TB, we'll add to this symptom chest pain, coughing up of blood, and the cough will be productive and abnormally prolonged. In case of the extrapulmonary TB, it will depend on the site of affection. As we see the figure in front of us, it shows the different areas of the body that can be affected with the TB and with its corresponding symptom and signs. So, what are the advances? These are old talk, the symptoms and the sign and so on. So, how can we use these symptoms for the diagnosis? We have advanced in the symptoms-based diagnosis. Symptoms of a childhood TB are non-specific, and up to 50% of children may be asymptomatic in the early stages of the disease. The use of well-defined symptom with a persistent, non-remitting character considerably improves the diagnostic accuracy. The presence of the following three symptoms at presentation will provide a very good diagnostic accuracy, which are persistent, non-remitting cough of more than 2 weeks duration, documented failure to thrive in the preceding 3 months, and unexplained fatigue. There are some physical signs. If it present, it's very highly suggestive of the presence of TB, like the Bot's disease in children, which just started as a gibbous at the back. This is mostly coming from the vertebral TB. Also, the presence of enlarged, non-painful, non-tender cervical lymph nodes with fistula formation. This is mostly TB until proved otherwise. There are other physical signs that just will need exclusion of the TB as a cause, like meningitis, pleural effusion, pericardial effusion, distended abdomen with ascites, non-painful enlarged lymph node but without fistula formation, and non-painful enlarged joints. Now we'll come to the important part, which is the investigation. We'll start with the traditional tuberculin skin testing. This skin testing shows the hypersensitivity to the protein of the tuberculous bacillus, which is acquired either by infection or by previous BCG vaccination. And we can take the measurement of this test within 48 to 72 hours after the test. It's considered positive in case the induration area is 15 millimeter or more in children without any risk factor for TB. On the other hand, I will accept it positive if the induration area is 5 millimeter or more in patients with high risk for TB, such as children living with an active TB disease, or children have the clinical symptoms of possible TB, or have radiological evidence of active TB, or immunocompromised child like cases of HIV. Although tuberculin test is cheap, available, easy to be done, but it has major limitations. These limitations in the form of the false positive results and the false negative results. It gives false positive result in case the infection caused by atypical mycobacteria TB, or there is previous administration of BCG vaccine, or allergy or hypersensitivity at the time of the test, or the presence of infection at the site of the test, Also, they are children I cannot control, so he can do continuous rubbing of the site of the test, which can make swelling and itching and gives false positive result. For false negative result, it occurred if the infection is recent, less than 8 weeks duration, or concomitant viral infection, or preceding live viral vaccine less than 3 weeks duration. Also, in case of chronic liver cell failure and renal failure, in cases with immunocompromission like corticosteroid therapy, malnourished diseases. So we come to the next test, which is the Quantiferon TB Gold test. Quantiferon is a simple blood test that aids in the detection of Mycobacterium tuberculosis. It is an interferon gamma release assay commonly known as E.U.P. E.U.P, this is a modern alternative to tuberculin skin test. It is a controlled laboratory test that requires only one patient visits and is not affected by the previous BCG vaccination, and this advances over the tuberculin test. It's highly specific, highly sensitive. It uses unique blood collection tubes that in front of us in the figure that enable immediate exposure of viable blood lymphocyte that highly specific TB. It has a lot of advantages, yes, but has also a lot of disadvantages. So we have limitation to the E.U.P test, which is it's one cut-off test, irrespective of the age, immune status, and TB risk factor. It has an unknown dynamics when the assay will become positive. There is discordance, and this happens when the skin test gives a result and the E.U.P gives a different result. Also, we have limited pediatric data about this test. In addition, in 25% of children, it gives indeterminate results, which will decrease its utility as a screening tool. And in malnourished children, also it gives 25% of indeterminate tests. We came to the bacteriological confirmation. We obtained specimen from the suspected site of affection, and this specimen will undergo staining with acid-fast bacilli, TB culture, and gene experts. We have different ways of obtaining a sample, whether it's pulmonary TB or an extrapulmonary TB. For pulmonary TB, we have expectoration. We have common ways of obtaining the sample, which is expectoration in elderly children and adolescents, gastric aspirate for younger age and needs hospitalization, sputum induction in case of failure of the gastric aspirate, followed by nasopharyngeal aspiration. And the most important and the new one is stool sampling. The use of stool specimen is based on the same concept as the gastric aspirate of retrieving mycobacteria from the swallowed respiratory secretions, since mycobacteria travel through the gastrointestinal tract and is excreted in the stool. This is very important and up to date by the WHO. Stool testing with expert has a sensitivity equivalent to that of the respiratory samples in older children and those with extensive disease. For extrapulmonary TB, it will depend on the site. For lymph node, we'll take 5-needle aspiration, if TB meningitis, lumbar puncture, and so on. So we'll have the specimen, and we will start with the acid-fast staining and smear microscopy. This is the oldest microbiological test for TB. It's simple and inexpensive. It depends mainly on the direct visualization of the acid-fast bacilli after being stained with the Nielsen stain. But it has also limitation. The sensitivity of the smear microscope is very low due to its high limit of detection and the low bacillary load in children's respiratory secretion. Besides, overall sputum smear microscopy is positive in only 10 to 15% of children with probable TB. And at the same time, it remains the only accessible diagnostic test at primary health care levels in many resource-limited settings. Then the mycobacterial culture and identification is considered a reference standard for TB in adults. The viable microbacteria are cultured in solid or liquid media, but also the culture have withdrawn. Culture yield usually low, 30 to 40% in children with intrathoracic TB. The classical decontamination method used on samples prior to culture are known to kill up to 30% of the mycobacterial population. And if you are talking of children that are already post-bacillary, so it's very different to find a sample positive. Also, waiting for the culture confirmation will delay the treatment of the patient for a very long time, and the risk of dissemination of the disease, as I said before, in the first 2 years of life. Here is the molecular test, which is the G-Expert Mycobacterium rifampicin resistant. This was introduced by WHO in 2013. It uses amplification and real-time PCR for detection of the mycobacteria and rifampicin resistance in only 2 hours.
We have a red slide.
Recommendation for the WHO, because it's very important and have new advances. It depends on the point of care test, which is WHO latest module 5, which was about the TB in children and adolescents, released on March 2022. It stated that we need to have a point of care test, which ideal, standard test, cheap, available, and affordable for diagnosis of TB in children. So some recommendation of some tests were released by the WHO, like detection of lipoarabinomannan in urine using lateral flow assays, line probe assay for detective resistant to rifampicin isoniazide, also the PCR-based point of care test, which is Expert Ultra, and this gives more rapid diagnosis waiting for the culture confirmation. Also, it recommends the use of ultrasound for both extrapulmonary and pulmonary, and it strongly recommends the use of ultrasound as being quick, non-invasive imaging away from ionizing radiation that doesn't require sedation or anesthesia. To conclude, WHO recommendation.
شكرا محاضرة جميلة رائعة بجد، بس هو فرق الوقت معلش فممتازة. شكرا دكتورة دينا. دلوقتي طبعا